I think I'm seeing double. What is happening to me? Am I going to be okay?
A man in his 60s suddenly developed double vision. It went away. Then it happened again. He had just undergone a heart rhythm procedure for atrial fibrillation, so he wondered, is this a harmless side effect, or could this be a stroke? Before going to hospital, he asked ChatGPT. The answer reassured him, so he stayed home. About 24 hours later, he was in the emergency department with what doctors diagnosed as a transient ischemic attack, a TIA or warning stroke. This is the danger of AI diagnosis. Not always that it gives a completely absurd answer. Sometimes it gives a plausible answer to the wrong question. Welcome to Clinical AI Academy Rounds, where we discuss the intersection of artificial intelligence and healthcare with the goal of improving AI literacy among clinicians. This case comes from a published report in Wiener Klinische Wochenschrift. The patient was a 63-year-old man who had undergone pulmonary vein isolation, a catheter procedure used to treat atrial fibrillation. 4 days later, he developed repeated, self-limiting episodes of diplopia, double vision. He was taking rivaroxaban, an anticoagulant, and he had already contacted his interventionalist. He was told that if the symptoms came back, he should contact a general practitioner or go to the emergency department. But during the second episode, he turned to ChatGPT 3.5. And this part is crucial. According to the case report, the patient was already thinking about stroke as a possible explanation. But he hoped the chatbot would give him a less serious explanation, something that would save him a trip to the emergency department. ChatGPT classified visual problems as possible after pulmonary vein isolation. That answer felt precise, it felt understandable, and it felt reassuring. So the patient stayed home. About 24 hours later, after a third episode, he called an ambulance. In the emergency department, his examination was mostly unremarkable, but he had mild sensory and fine motor symptoms in the left hand, enough to keep acute stroke on the differential. CT angiography and MRI did not show an acute infarct. But his symptoms resolved, and the final working diagnosis was transient ischemic attack. He was admitted to the stroke unit, his treatment was adjusted, and he was discharged 2 days later without residual neurological deficits. So what exactly did ChatGPT miss? It did not miss because it had never heard of stroke. It did not miss because double vision is impossible after a cardiac procedure. It missed the clinical frame. The patient was asking, could this symptom be a benign complication of my procedure? But the safer clinical question was, does recurrent double vision after atrial fibrillation treatment require urgent stroke evaluation? Those are not the same question. A chatbot answers the question it is given. A clinician reformulates the question. That is one of the most important differences between pattern matching and clinical reasoning. In medicine, the task is not just to list possible diagnoses. The task is to decide which diagnosis is dangerous, time-sensitive, and must not be missed. In this case, the red flags were not exotic. A man in his 60s, recent atrial fibrillation procedure, recurrent neurological symptom, double vision, concern for stroke already present. And a doctor had already advised medical evaluation if symptoms recurred. A safe response should have escalated the situation, not simply reassured him that visual symptoms can occur after the procedure. This is not just one unusual case. More patients are now using AI chatbots before they see a clinician. A 2026 Pew Research Center survey found that 22% of US adults say they get health information from AI chatbots, at least sometimes, and the evidence is showing a consistent pattern. Large language models can look impressive when they are given a complete, polished clinical vignette. But real medicine rarely begins with a complete vignette. It begins with fragments, a symptom, a fear, a missing lab, a badly phrased question, a patient who does not know which detail matters. In a 2026 JAMA Network Open study testing 21 large language models across clinical reasoning tasks, final diagnosis performance was much better than differential diagnosis performance. Failure rates for differential diagnosis exceeded 80% across all tested models, while failure rates for final diagnosis were below 40%. That is the key distinction. AI may perform well after the case has been cleaned, structured, and fully presented. But the dangerous part of medicine is often before that, and when the clinician has to ask, "What am I missing?" What is the worst-case scenario? What needs action now? A separate 2026 Nature Medicine study of ChatGPT health triage recommendations found that performance was weakest at the clinical extremes. Emergency cases were under-triaged in 51.6% of responses in the tested scenarios. That matters because triage is not the same as diagnosis. A diagnosis asks, "What could this be?" Triage asks, "How dangerous is this right now?" And for patients, that second question
So what
may
should
be the one that
clinicians do
saves
when a
their
patient
life.
says,
ChatGPT told me this. First, do not dismiss them. If you say, "Don't use ChatGPT," the patient may simply stop telling you that they use it. A better first response is, "Okay, what did you ask it, and what did it tell you?" That gives you two important pieces of information. The first is the AI output. The second is the patient's framing, because the prompt often reveals what the patient was hoping for. Were they looking for reassurance? Were they trying to avoid the emergency department? Were they afraid of stroke, sepsis, or medication toxicity? Were they trying to understand something a doctor explained too quickly? In this case, the patient reportedly found the chatbot's answer more understandable than the physician's explanation. That is uncomfortable, but important. It means the competition is not only diagnostic accuracy, the competition is clarity. If clinicians explain risk in a way that feels vague, rushed, or incomprehensible, patients may seek certainty elsewhere, even from a tool that is not safe for medical decision-making. So I would suggest a simple framework. When a patient brings an AI-generated diagnosis, ask 4 questions. 1. What exactly did you type? 2. What answer did it give? 3. What part reassured or worried you? 4. What symptom, medication, or clinical detail did you leave out because it seemed irrelevant? That last question may be the most important, because patients do not know which details change the risk calculation. A chatbot may treat the prompt as complete. A clinician should assume the prompt is incomplete. For patients, the safest way to use AI is not as a doctor replacement. Use it to prepare for an appointment. Use it to translate medical jargon. Use it to generate questions. Use it to summarize what you want to tell your clinician, but do not use it to decide whether a new neurological symptom, chest pain, severe shortness of breath, suicidal thoughts, or rapidly worsening illness can wait. Even OpenAI's own terms state that outputs should not be relied on as a sole source of truth or as a substitute for professional advice. That is not just a legal disclaimer, it is clinically sensible. So ChatGPT gave this patient an answer. But what it missed was the urgency. It missed the risk. It missed the clinical context. And most importantly, it missed the question that should have been asked. Medicine is not just naming a possible diagnosis. Medicine is knowing which possibility cannot wait. Have you seen patients coming to clinic with AI-generated diagnoses? How do you handle it? Let me know in the comments. See you in the next round.